You can talk as much as just don't have a serial quorum or a quorum. And that just came out, and I did put that to the chair, the vice chair, and a couple of other people. That here it is in writing, folks. The only thing they were stuck in is their policy. So the fact that it's true, we have it in writing from the Oregon Ethics Commission, written to Senator Dembrow. As long as you're not creating a standing quorum, like grouped together, or right. So pass the word, Charlie. Don't worry about talking to each other as long as you're not colluding to create a pre-vote.
Right. And it'll be interesting to see how it progresses. The first meeting of the Finance and Revenue Committee is not until October 15. And I've got a lot of things I want to say to the committee. See how that goes.
I want to say the second item, that is a big picture item, the biggest on the plate item for the Universal Health Plan Governance Board itself is to recommend a budget, right? As a board, as a piece of board strict business for them to vote on and make a recommendation for a budget. And it was good that the last meeting, they finally realized that, well, through some back, it's all about having these backdoor conversations, as you well know, right? And calling Bruce up, and who is on the committee, and saying, one of the committee members is saying, bring up the issue of budget. He says, "Oh, I'm going to have some backing." I said, "Okay, we'll get you backing." I won't get a serial quorum, but I'll get somebody to say it's time to talk about a budget a budget for doing the work.
Yeah, a budget for the work, not for the plan itself. Yes. Yeah.
Yes, for the work to get the plan.
That's a lot easier than coming up with a budget when you don't even know what the plan is going to look like.
Yeah. And part of what needs to be done in figuring out that budget is figuring out the expertise that we need. And my feeling is that a large part of that is going to be to see what expertise exists on the committees as it is, because I think there is some substantial expertise on some of the committees. So,
Mike?
Yeah, go ahead, Lynn. Sorry.
What is the composition of these committees? You mentioned the senator. How many legislators are on these committees?
none.
Oh,
what about that senator?
We have the advantage here that we are volunteer advocates in this group and not tied down by the partisans that might, if you're going to have a Republican, a Democrat, you're going to have a Republican and all that stuff. This is community-based people with a variety of backgrounds. I think we have to try to figure out, Charlie, right, where that expertise is for your area. We certainly have some people that are good in a couple of areas, but with a limitation of 9, it's hard to cover everybody. But that's a clarification that how we've advanced this work from being legislatively controlled at this point in time.
So to kind of build on that, there's 9 governance board members, but the committees, I think, have about 46 total, and there's 4 different committees right now. And so the 9 governance board members make the decisions, but there's lots of expertise that's on those committees that will advise the governance board, and then we're going to hire outside experts as well, and that's part of what we need to figure out. And the legislator that Tom mentioned is somebody who's very interested in the work and willing to come forward and talk with them, but he is not a decision maker about anything that's happening. And that's true for other legislators as well that are very interested in it. They will be making decisions on what the committee recommends eventually.
I remember what I was going to say. That once the budget for the board is decided, we learned from Washington that in their commission, the budget was approved and the money did not get to the commission in the ways that it was supposed to be. So it's more than just getting in a budget. You got to make sure that there's not ambushes and subtle diversions of the money you're allowed.
So that
This is
watchful eye is important. So that watchful eye is so important because you find out these rules later. Oh, we can't spend the money to hire the experts until it goes through this step-by-step approval process, which is going to take I don't know how many months they're talking about, right? Probably several months. Like they got the money budgeted, but how you can actually authorize to hire somebody is a series of steps that sometimes can take months, and putting out the request for proposals and how you're going to do the work and all that stuff. So that's a really good point, Mike.
This is deja vu for me because I was appointed to the Hawaii Health Authority in 2011, which is was established under Hawaii law to design and plan for a universal healthcare system covering everyone in the state. And we got appointed. I was one of the members. We got a budget from the legislature, and then the Affordable Care Act passed very soon after. And the governor pivoted to implementing that. And he went to the insurance companies for funding. And he took our funds from the budget and gave it to this new task force that was controlled by the insurance companies. And we got thrown under the bus. I hope you guys have better luck than that.
May I ask who makes the rules for those committees? When you say the rules say this, who makes the rules?
Okay. Don't mix up the rules. We're talking about the Healthcare Market Oversight Committee with the Universal Health Plan Governance Board. The rules for the committee are adopted for the board. The governance board are adopted by themselves. They self-adopt these boards, and that's where this thing that Mike mentioned to the end. Oh, we can't talk to each other. They voted that in themselves. They didn't have to vote it in, but somebody from the Department of Justice, out of line with statute, gave them advice. He should have never been there giving them advice on this. Didn't have any authority to give them advice, but did. They listened to it and they adopted this stringent rule. Well, a good thing is we did the pushing from many angles to say, this can't be right. And finally, the Oregon Ethics Committee has put that in writing. But the rule is still there for the committee that says we shouldn't, we have to, that it's very strict, but we shouldn't sidetrack ourselves on that for this issue right now. But the board makes itself its own policies for its operations. And I think one of the key things they've done is they've adopted their values and principles statement, which can be shared. I think that's a powerful thing that's been carried forward, Charlie, for how many years in legislation, kind of the same ideas, way back before 20.
I mean, it's been pretty much since 2013 with the, a lot of it was from the beginning of what eventually became the Rand report. So yeah, it's been quite a while. It's been some changes, but a lot of it is back from that time. I would also say that some of what the rules that Tom was talking about hiring is general procurement rules for the state of Oregon that are in statute and are not governed by the board. But so for the hiring of outside experts, there are lots of things that have to be followed that can take time. And that's just general procurement kind of stuff for the state of Oregon.
Lynn.
This relates to a further item. The reason the 2200 went nowhere in California is because Gavin Newsom created a commission that met for 2 years. 17 of the members, only three were for single payer. They came up with this unified financing scheme, which can include insurance companies. And I'm sure that's why he vetoed our fabulous bill early, because he's running for president in 2028 and he doesn't want single payer as an albatross. But we had a similar thing where the governor oversaw the whole thing, screwing single payer in California. And they came up with this SB 770, which was a unified financing bill. And So that's the situation that we.
So
we
one of
had-
the things
had
that
no
on
choice.
our, that set up our governance board, everybody who applied to be a member of the governance board had to say that they supported the objectives, values, and principles that were in the bill that we Tom sort of mentioned already. And so, you know, nobody really checked to see if they really did agree with that, but I think they all do. So I think we actually do have a group that I would say pretty much everybody supports and understands that single payer is what we need to have. And then it's just a matter of, can we really get there?
And I think over 160 people applied to be on these committees, so they picked 40. I don't know how they decided how many number on each one, but I think that was also a question in applying for the committees. Do you support this work? You had to say yes or no. It didn't say maybe. And I think you're looking at the people, given the numbers and what I'm hearing from the people about the people I don't know, but the ones I do know on each committee, it's pretty strong. These are people that believe in this movement, you know, so which is lucky for us.
Okay, any other comments on the Oregon situation?
Do you want me to talk
The
about
next things on
healthcare
the,
market oversight or no?
sure, go ahead.
All right. The healthcare, this is for those that are aware or not aware, we have or by statute created the Healthcare Market Oversight Committee in this, which has to do with mergers and acquisitions of anything to do with healthcare, right? So this is unique for the country. And what we've heard is the country is watching Oregon to see where this is going to work or not, because it's mergers and acquisitions is a nationwide problem. I think a brief background on that is to understand the situation today is this mergers and acquisitions law arose from an advocate here, Mary Lou Henrich, basically, who our Medicaid provider, Care Oregon, was going to merge or join in with Providence Health System. And the worry was, oh no, what's going to happen to reproductive rights once the Medicaid system gets merged into a Catholic hospital system, right? And so this was stopped, and the law was passed really based on this issue. Without the foresight of this, I can't go into it, the volumes of work that have to do with United Healthcare now, Kroger, Albertsons, the largest hospital systems, multiple work. And so with these rules, they were adopted relatively quickly for that. And there was a lot of flaws in them, but nobody was anticipating that 3 or 4 years later, there's going to be all of this stuff going on in Oregon, right? And this mergers and acquisitions oversight group in the Oregon Health Authority really are not prepared to do the volume of work that has now been put before them. Why? Because the budget they were given didn't say you need 10 staff to do all of this work. But what's going on right now, well, people say, well, this is a model for the nation. Well, the message has to be, well, the idea is a model for the nation, but the way it's operating right now needs a lot of fixes. And I got on the rulemaking committee along with a couple other people from Mid-Valley, Bruce Thompson and Karen Christensen, you may know, and we organized to make statements and went through this line by line item. And when we dug in, we learned different pieces of this thing. So finding the little details, again, is extremely important when we're doing this work. And when we found out there was the Oregon Health Policy Board, which oversees the Oregon Health Authority, gave them some guiding principles. We were able to look at those guiding principles and the framework of the work and say, you're out of line, that these things don't match up. So we are in the work of suggesting multiple changes to the proposed rules, which were very minimal. Most of them had to do with changing the word shall to must, and very other little meaty items. And there's some things like emergency exemption that isn't well managed. So all of that testimony is available at the Healthcare Market Oversight Committee in Oregon. One of the most interesting on that Rules Advisory Committee was the Hospital Association, and they put in a disclaimer framework. So the Hospital Association is trying to overturn that in court, that statute in court, saying it's unconstitutional. So when they put in their statement about revising the rules, they had an intro statement saying, well, we're making some recommendations for revising the rules, but this does nothing to take away from the idea that we're suing you to put an end to the statute as an entirety. So that was a very interesting introduction. But we pushed on. They were going to give us one meeting. Magically, well, we did a lot of doing that as somebody's movement lawyering, finding out little pieces of language, sending messages to the right people, and we got a second meeting. And there'll eventually be a public hearing. And our strength is that we're trying to work on is to get the Oregon Health Policy Board, there's getting more and more advocates on there to take their oversight of the Oregon Health Authority in this area and not let the Oregon Health Authority run the show. So that's I guess that's the summary, and that can be questions.
Barbara.
Yeah, hi. I don't attend these meetings very often, but I did want to introduce a couple of thoughts. Right now, healthcare is the #2 sector on Wall Street, to the tune of $9 trillion worth of stock. And I think it starts there. And I'm part of the problem because my California pension, CalPERS, is a big player, not just in healthcare, but also in private equity. Massive amounts of money invested. Has there ever been any discussion amongst your group about a divest from healthcare and put your money in climate control, something like that?
Well, what I just for speaking for me personally, because I'm also a public retiree on a PERS thing, and I get my thing through the PERS, Public Employees Retirement System, my insurance. A couple of years ago, somehow the PERS board decides that United Healthcare can be a choice, right? Blue Cross is no longer a choice on the list. United Healthcare is a choice, right? And so in my own personal thinking, I would like to, on a smaller level, I'd love to get that choice away from the PERS retirees as a way of place where money goes. I think what you're saying is, I haven't heard of any discussion about going through the pension systems in Oregon that I know of, but it's probably a good idea.
Okay, thank you.
Okay, anything else on Oregon? Yeah, the other things on the agenda, new business, have to do with me reporting on what's going on with PNHP recently. One of which is several of us met with Senator Whitehouse staff. He's a Democrat from Rhode Island who has long been in favor of single payer. He was the co-sponsor of the Senate bill. However, he's also completely bought into value-based payment. So it was an interesting meeting, which we had 2 days ago. But we were able to, I brought up the experience of Hawaii, which, they, as I said, they sabotaged the Hawaii Health Authority and implemented Obamacare based on value-based payment aggressively. The dominant insurer has moved quickly to capitate all primary care practices in Hawaii that they could. And the result has been rapid rise in costs and high overhead for doctors that are driving them out of practice. And we have a severe and worsening physician shortage. So the results have been anything but what they claim that they were supposed to be. And we went on to detail the reasons that value-based payment can't work. I put into along with the agenda, when I passed that out to this group, I put in the 2-page handout that I prepared on why value-based payment can't work. And I'm offering that as something any of you can use if you like. The other thing is that we have latched onto the idea that even though we're a 501(c)(3) and can't endorse political candidates, now that Trump has officially disavowed Project 2025, we're going after Project 2025 itself as a nonpartisan issue and saying that what would this do to the Medicare Trust Fund? What would this do to Medicare beneficiaries if Project 2025's proposal to make Medicare Advantage a default choice and accelerate movement of toward the full privatization of Medicare? What if they succeeded in that? And one of the things we calculated is that it would drain the Medicare Trust Fund within 5 years completely. It would immediately put it into deficit spending and drain it within 5 years. And you would have even worse problems with doctors having to deal with unreasonable prior authorizations and beneficiaries stuck with narrow and ghost networks and not being able to get the care they need, and denials that are driving hospitals out of Medicare Advantage and all these problems. So we left them, they were saying, well, if value-based payment isn't going to work, what do you think we should do? And so I said, I think we should fix fee-for-service. There are admittedly serious flaws with the way fee-for-service works now. It hasn't paid for much of what doctors, especially in primary care, need to do, but we need to fix that. We don't need to chuck it in favor of something that has much higher overhead and opens the door to fraud and abuse. So I put the materials related to both of those things into the email to this group, so that it should be there in your email. Charlie.
So did you bring up paying by budgets? Because actually a larger quantity of healthcare could be paid for by budgets, because hospitals are a big chunk, and also large clinical systems could also be paid in that manner as well. So,
I did bring that up.
Thank you. Yeah.
They had a Senator Whitehouse and Senator Cummins, who's a Republican, have a bipartisan bill to improve primary care pay, and it's completely based on value-based payment. And they had a request for information on that bill. It came out a few months ago, and the window to respond closed in July, but they said, we would like your input. So I did include hospital budgets and the difference between budgets and capitation, and how there's a better way to do this in my response to that, which I sent out right away.
Thank you.
Tom.
Lynn's ahead of me. I gotta see her on the screen or not.
Yeah, speaking of Project 2025 and the impact on healthcare, are all the doctors groups besides PNHP, like the AMA and the others, coming up with plans to fight it?
I don't know if the AMA is specifically focused on Project 2025. It's hit the news fairly recently, and I don't know if they've had time to formulate a policy. Tom.
Going back to the value-based payments issue, a point of interest we had in our state legislature, still do till at least January. Maxine Dexter, who's running for Congress, is likely to get it will become my congressional rep in District 3, replacing Earl Blumenauer, who is a value-based payments, I don't know, hawk, I would guess I would say. I don't know, Charlie, I have an impression of Maxine Dexter, but she's been the one in the legislature and never really been the voice you could have been for the universal single payer system, just a sign on, right? So so for News for You doing work at the national level, we got to get to Maxine Dexter, who's going to come into that Congress and be a part of this value-based payments conversation. I can't see it not happening. There's other reasons. It's too bad that she got elected. There were a couple of other very good candidates in my district, but the split vote and the plurality ended up, she got through in the primary on it with a minority of votes. And because of the composition of this district is a shoe-in for getting elected. So just, I'm not on the best terms with Maxine Dexter at this moment in time, probably because of because of another issue that's close to a lot of people's hearts around the death and destruction in Gaza. And but keep an eye out for that. It's very kind of important, but I would like to get that information about the value-based payments because it'll keep popping up here in Oregon, I'm sure, again, and we have to, but having the strongest advocate in the legislature in Oregon gone to me is a good thing. And I don't know if we know anything about Lisa Reynolds, Charlie, as another doctor, whether Lisa is a value-based payments person or not.
I would say that she is likely, I don't know for sure. I would say she is likely she's not a hawk on it, but she's likely a mild proponent at least. And so it would be good for, it would be nice, actually. I think it's for us to set up a meeting and invite Steve to be part of that with them after they get elected, because I don't think they're going to be listening before that. Although in many ways it's better to get them beforehand. But so
one of the striking things about meeting with Senator Whitehouse's staff is they had heard all the talking points for value-based payment. Fee for service is a problem. This realigns incentives, and we can incentivize equity and cost savings and all these things like that. And I said, have you considered the perverse incentives that are inherent to capitation? If you're going to pay the average pay off the sick, so you have a great incentive to gain your risk pool, and to try to correct that, they've got risk adjustment, which is it's impossible for it to be effective. So that then you got a upcoding problem, and along with all that, there's still the problem of this incentive to deny necessary as well as unnecessary care. And these are all built into capitation, and nobody's talking about them. They had never thought of those things. Hank?
Yeah, so the rubric of value-based, I think you've touched on it, and it could be used like a tobacco company and the oil companies use the let's do another study, and the solution is not, so it's a diversion and a delay tactic. Let's study this for another quarter, or it turns out 20 years, the value-based rubric as a way to defer. The other question is again, your new rep who's bombarded with things and doesn't know what universal private single payer is, and so we'll grab the rubric of value-based. There's two examples for us here in Maine is Maine Medical Center, Maine Health, which is the big dog in the state and does 40% of the care and is the most expensive healthcare system in New England because it basically has a market capture. That came out in the press about 6 months ago. So 2 weeks later, the CEO of Maine Health was called in front of the Chamber of Commerce in Portland to give us a talk, as to why are you the most expensive, to business members. And other than talking about, well, we do quality and healthcare is expensive and quality is expensive, something that slipped out of his mouth is fee for service is the problem, and we will correct the cost problem with the value-based rubric. Now, this is a guy who was a family practice doctor initially, and now he's a CEO of a, quote, he knows better, shall we say. But again, he has to throw something out to the business community. Value-based healthcare will solve your healthcare problems. And my response, and when I give lectures is, well, the Europeans do it for a third less. What's their solution? And there's no way that value-based has ever been shown to save more than 1 to 2%. So I can offer you a 20, 30% solution, and value-based offers you a 1 to 2% maybe solution with a lot of extra. So the idea is that when you hear value-based from your representative, or from, I was going to ask what Senator Whitehouse, has he, what's the thing he's grasping on, because he's probably not totally there, shall we say, is I need something to throw in front of Dr. Kemble as well as the voters, and value-based will be that rubric that I will use. So we have to come up with a way to counter that. The other thing is in Maine, our Maine Medical Association has come up with a fairly strong, universal single payer statement. But the task is, how do you convince the average physician in Maine that it's better on the other side? Okay, that will be better. So we've had conversations with the heads of the medical associations in New Brunswick and Nova Scotia to try to get some understanding what it's like to be a physician there. And of course, one of their comments is a physician in Canada gets paid on a fee-for-service basis. There's variations, but everybody is an LLC. Nobody's an employee. Nobody has a value-based rubric that they work under. There are some exceptions, shall we say. But so the idea is our framing of fee-for-service is the predominant reimbursement model for practitioners in the rest of the world. How come they do it for 20 to 30% less? In other words, that value-based rubric is barking up the wrong tree, number one. And number two, you may be actually being fooled by the health insurance company and the large hospital corporate entities in healthcare, because they want to defer and deflect from other solutions. So again, Steve, your 4 points, I sent that email out, is fee-for-service is the predominant model in the rest of the world. Explain to me how they can do it for 20 to 30% cheaper. So that would be one of the questions I would ask to Senator Whitehouse and to your upcoming representative in Oregon, who is saying, well, value-based is a problem. I said, yeah, but nobody else does value-based like we do in the United States, and they do it 20% cheaper. That's not the avenue you want to go down. So
one of the things that I had in my blurb that I passed out to Senator Whitehouse staff is that the literature on value-based payment claims that it saves Medicare money. Some of that literature only talks about what Medicare spends directly for healthcare and leaves out the bonuses for meeting quality and quality metrics and bonuses for those kind of things. And if you add the bonuses in, almost all the studies I've seen show either it's a slight, maybe less than 1% savings, or it costs Medicare more than fee-for-service would have cost. Almost none of those studies mention the overhead costs to the practice or the ACO or the Medicare Advantage plan to run a value-based program. And this is not a cost to Medicare. Medicare may save 0.5%, but if the entity that has to deliver the care is suffering 15% higher overhead, they end up losing money. And a lot of the ACOs that have been the most successful drop out after a few years, because even though Medicare is saving a small amount off of them, they're losing money and they can't afford to continue, so they quit. And so no one's looking at the overhead to whoever has to implement it. And the last thing is they don't look at the fact that, and we know this is true, it's been widely proven in policy studies and things like that, that capitated entities can capture a healthier than average risk pool. And if they do that, which Medicare Advantage plans certainly do, then they automatically get lower costs and higher quality metrics because their population is healthier in the first place, even if they do nothing to improve care. And nobody accounts for that in these studies. And these things have to be pointed out.
I think the simple answer is any clinical savings that's made in value-based care by getting grandma home a day early and having a nurse visitor, any clinical monetary savings is eaten up by the administrative complexity to organize that care. So that's the simple answer. Any clinical financial savings are consumed by the administrative bureaucracy to implement the service. That would be the simple 15-second answer to your representative who says, well, value-based care is the way to go. I said, no, 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 no. This point 1, point 2. So that would be the summation, the elevator speech.
The other thing is the outcomes. You look at states that have aggressively implemented value-based payment. Hawaii, it raised our costs of driving doctors out of practice. Vermont, they have a statewide ACO. Their costs are right behind Maine as the most expensive in the country. And they've been rising 10% a year since they implemented this. Connecticut is the counterexample because they fired their managed care companies in 2012 and their costs came down 14% 6 years out. And their doctor participation improved, ER visits and hospitalizations declined, and their administrative costs dropped from 15 to 20% to 2 to 3%. So those are the real world counter examples.
Yeah.
Charlie.
So my ask again is I need studies that specifically or articles that specifically outlay that difference, but thanks.
Yeah.
My screen shows Barbara first. If you go to left or right, it always shows the order in which people have put their hands.
So Barbara and then me, yeah.
Yeah,
Okay.
okay. I'd just like to introduce another idea. You may or may have not heard about this. Medicare has a great program. It's called Medicare QMB. What it is it's basically people who qualify for Medi-Cal and Medicare. They become something called a qualified Medicare beneficiary. And it is great. Okay, it's totally government run between the state and the federal government. They both put money into it. And the person basically has Medicare, Medi-Cal. They get no cost sharing when they go to the doctor, no premiums, no deductibles. They get extra help to help with their prescription drug coverage, and on and on. You can even get the figures on dental and vision and probably long-term care for people that go on to Medi-Cal, long-term care. So the evidence, the cost and everything are right there for us. And I truly believe take off the income requirement and we've got what we want. So I'm going to put the link from CMS into the chat, and you can take a look at it later. Okay, I think it would be. Go ahead.
As a cautionary note, what's happened in a lot of places and is increasingly happening is when you have dual eligible beneficiaries, you have Medicare and Medicaid, the combination covers everything, like you say. But what happens is the Medicaid managed care companies then force their dual eligibles into their Medicare Advantage plan. So now you have Medicare Advantage and Medicaid, and then they can impose restricted networks and denials and prior authorizations and all that kind of stuff. So it's being damaged by all these companies that want to convert their Medicaid dual eligibles into Medicare Advantage plans, and then they can game the payment system and get overpaid by CMS as well.
Right, that is a problem. It's the private industry is intruding into this, but by itself, it's a really good program.
It is. Yeah.
And when people get it, they are just ecstatic in terms of customer satisfaction. They've got the gold now, except for the fact they have to go to doctors that take both. That's an issue. But anyhow, I just want to introduce that idea. My phone's about to run out, so I'm going to try to get this link in the chat. Okay, thank you.
Okay, who's next? Because I can't tell from.
I think I was, but
Okay.
because I somehow got my hand unraised. So I just wanted to caution a little bit when you're talking with Sheldon Whitehouse. Rhode Island is one of the very few states where they've increased Medicaid managed care at actually lowered costs. I mean, so Rhode Island is an exception to the general thing. I mean, I've looked at very carefully at a lot of state data, and they're one of the few exceptions where you could actually look at the data and say, oh, I guess managed care has worked there. And I would say the same thing for Rhode Island's Medicare, whatever that program is that we're the value-based payment part of Medicare, traditional Medicare. So anyway, Rhode Island is one of the weird states where you could actually look at the data and say, oh, it actually has helped. So Sheldon Whitehouse is not actually ignoring the data, because in his state, unfortunately, well, I don't know about unfortunately, it does seem to have helped, and I have no idea why. I can't figure out why they seem to do okay and nobody else does. I mean, you would expect nobody should, but somehow they're doing okay with it. So it's bizarre in my mind.
Tom?
I want to bring this back to a little bit of a homegrown stuff, Charlie. Maybe you're already picking up on this. I think it'd be really good to introduce a value-based payments conversation, bring these people on to discuss this and try to get ahead of the curve and the discussion. And you wouldn't need to have the expertise hired through the state to come to the Universal Health Plan and Governance Board, or we could find some legislator through Deb Patterson or somebody else that would be willing to have a real hearing on the value-based payments if we could get ahead of it right here in order, sort of cut it off, right? The other item is this idea that Barbara just said, which was this, we have the same thing here. People can get on Medicare and Medicaid, right? And this combination, and they feel so relieved. And so we're looking at that financing system, that combination of dollars or service. I don't know, Charlie, maybe that's, also something that can be, what does that look like, where people are getting this, right? And it's working out really well for them with the no co-pays, no premiums, things that we could already start to work on without waiting for too many meetings of the financing group. I would like to hear, I know for time for a minute, who in California knows about what's going on with your own waivers, because that has to do with what we're doing here in Oregon as well. I'm not sure if that's part of your conversation today or not. Thanks.
Lynn?
Well, to answer his question, Tom's question, the Ash Kalra, the author of our single payer bills, went to Washington and met with HHS people. And the 1332 waiver, they told Ash that all you need to do is have a bill, a law, and then we'll look at the waiver. But Michael Leidy decided to write a bill, 770, which was supposed to get a waiver. But there was no single payer bill that he worked on to use the waiver. He did get let go from CNA in 2018, and some of us feel this was a way to sabotage our bills. And it really went nowhere. So there already is, like Carmen Comstein, the author of bills, there already is a waiver process. You don't need an extra bill to do it. Now, that comes into SPUCA, which we're going to talk about. That's the advantage of passing SPUCA, and Chuck can attest to this, and because that's going to make waivers easier, and it is suggesting regional single payer, like New England has a bill, the West Coast has a bill. And Betty, Keller said that because Vermont is such a small state, that's why they didn't do well. So that Vermont is a perfect state to link up with New Hampshire, Connecticut, and do a regional single payer system. My other comment was, I just got in the mail yesterday, and maybe you're aware of this, but United Healthcare has come up with a new supplemental scheme, and that is to include all the perks of Medicare Advantage. Now, I got it yesterday. I was planning on calling today to ask how much the premium is, but they're now offering gym membership, dental, hearing, vision, a 24/7 nurse advice, etc. So are you aware that United Healthcare, who's already $1 trillion, is now offering supplemental Medigap plans that have the Medicare Advantage perks in them.
It's all over TV advertising. But I don't think it's good, it's not gonna be the panacea it is. People are gonna be paying.
It doesn't make any sense for them to be doing that unless they think it will be a portal to steer people into their Medicare Advantage plan. Because that's where those things pay off, because you capture healthy people and you can then control their care. Whereas with a regular supplement, it's it has to follow Medicare benefits and Medicare providers and all that, and they can't do any of that managed care stuff. So the only reason they would offer carrots like that is that they think they can use it to steer people into Medicare Advantage. I can't imagine any other reason.
And you're aware of Humana
Barbara.
dumping 500,000 people?
Yes. Yeah, that's because they didn't get the big increases in money from Medicare that they had hoped for. Barbara.
I think it's from before. She just forgot to lower.
Oh, okay. Mike?
Yeah, I just sent testimony to the governance board about the flaws in value-based payments, because they had a presentation the last meeting, September 19th, on how the Cost Growth Target Committee from the OHA had done this tremendous research over the past 4 years. And there's a lot of good data in there, but the drift of all that data was how to apply it to a value-based payment system, and kind of ignoring that the primary goal of this board is to create a single payer system. So I sent basically a paraphrase of what you've said in this document you sent us, but they don't know Steve Campbell. I think of Steve as the oracle of truth, but can you put any references that back up what I think is very persuasive argument? Or maybe you already sent it to me.
I had to slap that together quickly, so I didn't have time to get references. But yes, absolutely, there are references. A lot of them are in the PNHP reports on overpayment of Medicare Advantage and the harms caused by Medicare Advantage. That's fully referenced. And if you pull up those two reports from PNHP, you pretty much have everything you need.
I'm thinking, sorry to take advantage of this meeting, but I'm thinking when your committee gets started, Charlie, having somebody like Stephen come in and talk to the committee would be you're already there, I'm sure you're ahead, aren't you?
Yeah, well, so to me, I would really like to get Steve in there, but I think, and I've mentioned this before as well, and that is most health policy people within the US don't understand how Canada pays hospitals, I don't think, and it would be really good to have somebody either from a CEO or CFO of a Canadian hospital, or somebody from a government entity that pays those hospitals come in and describe how it works, and that's part of, I think, what needs to happen is to say, yeah, there's places where fee-for-service shouldn't be used, and here's what should be used instead. And I think it's really important to
Who's the chairs of your committee? Who's the chairs of your committee?
Well, currently, the chair of my committee is Warren George, and but what's going to happen when he leaves after November, I don't know. So I'll find that out probably next month. But I can probably find out from Warren.
But Warren could do the invite right off, because he has that power as chair to set that kind of thing.
Yeah, I that's a good idea. I will talk with Warren about these things, and I think I think that first meeting, though, we might have to do some other things. So we'll have to see. I'll have to think about this a little bit, how we could do this, because I've got a lot of things I wanted to bring up, mostly about the lack of believability about credibility of a lot of the data that exists related to current expenditures in Oregon. So.
Lynn?
Yeah, I just got an email from Chuck. Regrets that I couldn't make today's OPS policy meeting. My housemate was stranded in a downpour. If it does or does not come up today, thanks for considering helping the Sabuca work group on the question of how we will transition from a successful state-based UHC, United Healthcare Program, to national Medicare for All, looking at Canada and other related models.
Well, Stephen looks like he's fading in and out there.
Yeah, I'm in my car and I was blocking my daughter who has to go to work, so I'm moving the car out of the way. I'll be right back.
Okay.
Sounds like we have a topic for the next policy work group meeting.
Yeah, I think we're out of time for today, but yeah, we should put that on the agenda for next time.
Also, the PNHP National Board will take up the topic of state-based universal healthcare, as I understand it, Steve. And I will be there and finding a table or a corner at the meeting for anybody interested in promoting the state-based universal healthcare. I think the momentum is shifting a little bit in our direction.
I would say that they've decided not to. The way they're organizing this meeting this year is around the current campaigns, one of which is not state-based. But I don't think there's anybody currently on the board who's rabidly against state-based. All of them feel the same way I do, which is that it's a parallel effort. They complement each other. And even if PNHP isn't going to be a central voice for state-based, they are all in support. Okay. See you all next month then.
Thanks, Steve.
Okay.